For a bacteria to be karyogenic, it should be able to form complexes of carbohydrates, should have low pH survival, should undergo rapid glycolysis and rapid transport of carbs. Sucrose is also karyogenic in nature. The reason behind is sucrose is composed of fructose and glucose. When Streptococcus mutans acts on these, fructose converts into fructans and glucose converts into glutans. Glutans further is divided into dextrans and mutans, out of which mutans is least soluble in saliva and has more tendency to adhere to the tooth surface. It is more resistant to the enzymatic attack, and therefore it is an important constituent of fibrillar plaque matrix. So the bacteria which is responsible for smooth surface caries is Streptococcus mutans. For dentinal caries, it is lactobacilli, which is both acidogenic and acidiuric. It is a secondary invader. And for root surface caries, actinomyces is responsible. It has low acidogenic potential and it has no effect on enamel, but it can cause decalcification of cementum. Now, what is fluoride bomb? Fluoride bomb when Pitt and Fisher caries are seen on outside, but there is a big caries lesion inside. Based on the number of surfaces, caries are divided into simple, compound and complex, and based on the levels inside the tooth which it invades, it is divided into 4 levels, D1 to D4. D1 is clinically evident, but there is no cavity and white spots could be seen. D2 when the cavity is involving enamel, D3 till dentine and D4 till pulp. If we see the microscopic changes in enamel caries, there are 4 zones. First is surface, second body of the lesion, third is the dark zone, fourth is the translucent zone. We see the porosity and demineralization in all these surfaces. In the surface, porosity is less than 5% and 10% demineralization. In the body of lesion, porosity is 25% and demineralization is almost same, 24%. In the dark zone, porosity is 2 to 4% and demineralization is 6%. Translucent zone में porosity is 1% and demineralization is also 1.2%. For a normal enamel, there is no demineralization and porosity is also 0.1% only. Next is dentinal caries. So it starts from decomposition, then bacterial invasion, which is not capable of remineralization, then demineralization, then sclerosis, and at last there is fatty degeneration. This is the order from the surface, that is the outermost surface of enamel, to the pulp. Now some important points to remember. Stephen's curve is seen in more caries prone and less caries prone individuals both. Then fluoride is more in plaque and less in saliva. And initiation of caries does not depend on developmental defects of enamel. It has no relation with that. And last is frequency of sugar taken is more important than its quantity. There are 2 studies for sugar. First is Weipholm study and second is Hopwood House study. Weipholm study is done in Sweden in a mental asylum, and Hopwood is done in children of 3 to 10 years of age and continued for 10 years, which saw conclusions as decreased carbs, increased raw food or Spartan diet, which leads to decrease in caries. That is, decreased carbs lead to decrease in caries. In Weipholm studies, the conclusions were increased carbs led to increased caries and vice versa, and retention of food items, if it was more, then caries also increased.